Hello, my name's Adam Winstock, and I'm really sorry I can't be there today. I think I'm the one missing out because having looked at the programme and being aware of the incredible organisation that Ian's put in to make this event happen, I really wish I was there in person to be able to kind of talk with people and learn more about what's a hugely important problem. I guess for me, the three things I'd want you to walk away with today is an understanding that there's not going to be a pharmacological solution to what is a deep social problem. I think the second thing is that doctors have got an enormous role to play as the gatekeepers to these prescription medications, and we can be influenced and supported hugely by our clinical colleagues, our nurses, our pharmacists, even our commissioners. But the third thing is that got to make sure that people who have genuine pain needs, even if they do have a history of drug and alcohol problems, aren't denied medication that's going to make a huge difference to their life. It's a real tightrope to walk, and it's a difficult balance to get it just right. But that's why I guess we have jobs. It's our responsibility to do really good assessments and make sure people get the best possible care. So I'm going to run through some things that I think are of clinical relevance over the next 15 or 20 minutes, and hopefully this will be a useful contribution to the rest of the day. My conflicts of interests are that I'm the owner and founder of a Global Drug Survey, and Global Drug Survey has provided a number of data reports to pharmaceutical companies, and I've also written several papers on issues related to drug diversion. Today what I want to run through is the whole idea that nothing ever related to drugs, particularly prescription medication, is black or white. I'll use some of the Global Drug Survey data to illustrate this point. I want to talk briefly about some of the different qualities that different medications have and stress the idea that there is no pharmacological solution to social problems. I'll talk a little bit about some of the newer medications such as pregabalin and tramadol and their risks. And I just want to finish off highlighting the association between depression, which is often missed, and pain, and how this can impact on both our assessment and management of people to whom we prescribe prescription opioids. And finally, I just want to stress that doctors really should know better, and I think we should be doing more. But I think one of the things we also need to do is to recognise that patients need to know better, and doctors can be part of that process. And I'll just finish by giving you an example of a Dear John letter about how we can perhaps engage and inform patients better. So Global Drug Survey runs the biggest drug survey in the world. There's a huge network of partners that we work with in order to create both the survey and produce a range of free apps. And we are committed to helping people use drugs more safely, regardless of the legal status of drugs. We also publish a number of peer-reviewed papers, about 5 of which do cover areas of prescription drug misuse. I guess it would be really lovely if doctors were able to do an assessment and figure out the patients who are good. Good patients would be those people who have a genuine painful condition, where opioids are appropriate, and where patients are fully compliant. They take their medication every day, and they only ever take their medication to relieve pain. And at the same time, doctors were able to do an assessment and we'd be able to figure out which patients are bad. Bad patients would be those people who don't take their medication to manage pain. They don't comply. They use their medications to modulate their mood, to help them sleep, to relax, to relieve boredom, to get high. Maybe they share their medications or they mix them with other drugs. Unfortunately, it's really difficult to do that assessment, but most importantly, there is a huge overlap between those patient groups, and lots of patients who genuinely use those medications to relieve pain will on occasion take an extra tablet to maybe make them feel more relaxed or to deal with poor sleep or maybe just a bad day. So both patients and their conditions are dynamic, and it's not a case of figuring out good patients from bad. And that separation also exists for drugs, because it would be lovely if there were medications that were nice drugs, nice medications, safe medications. It would be easy to think that medications like codeine, DF118s, buprenorphine, tramadol, pregabalin were drugs with low levels of abuse, but that's not the case. And of course, it would also be really nice if we were able just to lump together all the drugs that were bad: oxycodone, hydrocodone, morphine, short-acting potent opioids, if we could suggest these were bad drugs that we shouldn't use. But exactly like patients, there is an overlap, and it's about how people choose to use those medications that really determines whether or not they're going to cause problems. That is not to say that there are things around medications and their effect profile that does make some medications more likely to be misused than others. But it's not that simple. So if you think about prescription opioids, and there are many prescription opioids, that they vary widely in their potency, their duration of action, their precise receptor effect profile, their formulation, and they do vary in their abuse liability. But as I've just said, it's also dependent on other factors, perhaps most importantly, the prescription that they get. Are they given a prescription that means they have to pick up medication every day, or do they get a repeat prescription with a monthly pickup? Is there any prescriber review? What's the availability of other drugs in the community? What's the cost and the cultural demand? All of these things come into play. And particularly, I think, when we think of prescription opioids, there's also the issue of pharmaceutical advertising, both to the general population and doctors. I'd also ask you to not believe the hype. Typically, when a pharmaceutical company loses a patent, they will try to come up with something that maintains their profit margin and dominance of the market. And they also get put under pressure by governments to come up with solutions to abuse and misuse. But tamper-proof, abuse deterrent preparations are not abuse-proof. Adding naloxone to buprenorphine does not stop people getting dependent on buprenorphine or misusing it. Tamper-proof oxycodone might mean it's more difficult to inject, but you can still get a really nice habit on it. And there is no obvious pharmacological or formulation-based solution to a deeper social problem. And I don't want people to rely upon the fact that a drug company comes up with an answer that's going to magically waft away all the problems we have. It's not going to happen. Because basically, heroin in a pill is still heroin. I want to very quickly touch on some of the work we've done on prescription opioids coming from Global Drug Survey 2015. We've published a number of papers in this area that if you want more data, you can go and look at. What we were interested in GDS 2015 was looking at the whole idea of non-medical use. And non-medical use of prescription medication is defined as using drugs that were not prescribed to you by a doctor, or using drugs in a manner not intended to by the prescribing clinician. For example, getting high. But there's a whole range of other non-medical uses. And these are things to alleviate sleep or mood problems, to help with boredom, socialization, sex, or study. All of these things aren't in the BNF as indications for prescription opioids. So we looked at which prescription opioid medications were most likely to be used to get high over the last 12 months. And there is clearly a hierarchy of abuse liability. And the order, not surprisingly, is oxycodone, hydrocodone with the highest abuse liabilities, with the lowest rates for morphine-based products and codeine. One thing I'll draw your attention to is tramadol rates. And you can see America just tops the rates of abuse for every country, for every medication. But tramadol actually isn't a drug that seems to be abused terribly by many countries other than the US and the UK. And I'll come back to tramadol a bit later. Of course, one of the reasons America has such a problem, particularly with OxyContin, was due to direct advertising by the pharmaceutical company. And if we look particularly at the US, we can see the consequence, not just in the huge number of overdose deaths every year, but even just in the simple data that we've got from Global Drug Survey, where you can see the rates of using any prescription medication to get high in the last year was over 35% in the US compared to just 17% in the UK. There are consequences of poor regulation and dodgy advertising by pharmaceutical companies. And that's also linked to the huge investment that pharmaceutical companies invest in advertising their products. So here's year on year advertising for OxyContin over the first 5 years of its release. And you can see it, they invested lots of money. The consequence of that was a huge number of increase in sales and a big increase in the number of deaths. And I'm going to come back to the idea that promotion plus sales equals increased availability, misuse and overdose rates. And they just go together so beautifully. We were interested to see where people were sourcing their prescription opioids from. And what this slide here shows
is that regardless where you look in the world, it is still doctors who are the biggest gatekeepers or dealers of prescription medications, almost 3/4 around the world. Of course, in some cases, people are given medication. That's medication being shared or perhaps sold by friends. Access through dealers is actually relatively small, and certainly when we did this 3 years ago, the internet was still a relatively small contributor to source. My guess is over the last 3 years, with the growth of the darknet, this has now changed. The other bit I was really interested in, particularly as a doctor, was whether or not doctors were taking their responsibility and raising the whole issue of risks of dependence with their patients. But rather depressingly, both in the UK and globally, just over 25% of patients reported that their doctor had discussed the issue of dependence. It really should be almost all. And then we asked how easy would it be to get a prescription, and you can see that around 25-30% said it would be pretty easy to get a script for prescription opioids in the next 7 days. So what are the kind of telltale markers of problematic use? And by non-problematic use, I mean taking more than was prescribed, trying to get hold of extra medication, being unable to stop or cut down, experiencing withdrawal when you try and stop, mixing it with other drugs to enhance the effect, particularly alcohol, or overdosing. And when we look at both the markers and rates of these, what we can see is that it's about 1 in 5 patients reported 2 or more of these kind of markers of problematic use. It's rather similar to the proportion using these drugs to get high, about 1 in 5. Rates of injecting, of course, are very low, and I guess that's partly because they're not really the best opioids in the world to inject. I think one of the other really important findings is that people in receipt of prescription opioids, a significant proportion, almost 1 in 3 globally and in the UK, said they were interested in using less medication the following year. And that means that there is a population that would be motivated to engage with doctors who spoke to them around risks of dependence and also were supportive of them trying to reduce the amount of medication they used. When we did some analysis looking at the risk factors for people using these medications to get high, fairly consistently, you were more likely to use prescription medications to get high if you were young, male, had higher rates of alcohol problems, and cited non-medical sources. And I think some of those things you should be able to spot on a good initial assessment. But whether or not you end up with a problem, it's always going to be a result of individual factors plus the drug plus the context that they're in. And that context might be other drugs that are available in the community or perhaps pressures on that person in their own life. And the bit I'm really interested in is the role of the doctor. If doctors didn't prescribe as many prescription opioids, there would be less problems. In response to rising concerns over the problems related to prescription opioids, a whole new generation of medications came out. And I think one of the first ones was tramadol, which is a semi-synthetic opioid whose mechanism of action isn't just mu receptor agonism, it also modulates monoaminergic transmission, and you can't actually negate all of tramadol's pain-killing effects with naloxone. The problem with tramadol is that in overdose it's pretty fatal. And what we can see, particularly in the UK where there was a lot of advertising, sales went up. Sales also went up because it suddenly became a very cheap drug when it went off patent for doctors to prescribe. But whenever sales go up, you also get an increase in the number of people dying. And you can see a very slight turn down over the last kind of couple of years, and that was to do with perhaps changes in tramadol's scheduling. But certainly in the UK, in 2015, tramadol was mentioned in 12% of drug misuse deaths, and deaths continued to rise every year till around 2014. That was a threefold increase since 2009. And of the 254 deaths due to tramadol in 2013, almost 40% only involved tramadol. Polydrug use with other CNS depressants such as alcohol and opiates were present in many of the other deaths. We did some work looking at tramadol use in the UK, and what we found was 44% had reported using tramadol for reasons other than pain relief. And these were people who were prescribed it very often for genuine pain conditions. And I guess it just makes the point that it's not a case of patients being all good or all bad. People vary in their motivations over a period of time as to why they may use medication. And the difference between a dose that gives you pain relief and a dose that gets you relaxed or high is maybe a tablet or two. Tragically, of course, a few more tablets, particularly if you've got alcohol on board, may lead to your death. And people do develop full-blown dependence on tramadol. And tramadol withdrawal looks very similar to opiate withdrawal. People feel achy, they crave the drug, they get excessive lacrimation, they're sweating. And the way we would treat people with tramadol dependence would be almost identical to that of heroin use. And typically, I would be transferring patients onto either buprenorphine or methadone and detoxing them or maintaining them as required. Pain remains an incredibly common condition in the population. It's about 1 in 4 of the population report chronic pain at some point in their life. But importantly, opiates aren't just good physical analgesics, they're really good emotional analgesics. And I want to remind you about the incredible quality that opiates have, which is of narcotic comfort. The best description of heroin I think I've ever been given by patients was either it's the best antidepressant in the world or it's being like wrapped up in emotional cotton wool. And patients with a history of PTSD or depression as well as genuine pain will find opiates an attractive drug. So as I said, the lifetime of prevalence of pain symptoms in the population is really high, and major depression's really high, about 5 to 10%. And the conditions have got overlapping symptoms, emotional and physical distress, fatigue, and I think that the problem for doctors is that when patients present with pain who are also depressed, you tend to kind of miss the depression because patients go, I'm miserable, I'm not sleeping, I'm not happy, and doctors go, oh, well, that's just because you're in pain. The truth is that untreated depression makes pain difficult to spot and treat effectively. And unfortunately, having that comorbidity actually means your outcomes are worse than for having either condition alone. Now, that there is a neuropharmacological link between pain perception and mood. So depression is typically thought to be associated with a reduction in monoamines, particularly serotonin and noradrenaline. And what we know is that both of those neurotransmitters reduce and dampen peripheral pain signals. So basically, if you're depressed, you're more sensitive to pain. What that means is that if you optimize people's treatment for depression, you can actually help them manage their pain better. Conversely, if you don't treat somebody's pain effectively and adequately, it'll be very difficult to bring about significant changes in their depression. Of course, there are other ways not related to drugs that are useful to both deal with both pain and depression, and that would be something like CBT. Another response from, I think, the pharmaceutical industry was to come up with novel analgesics. So both pregabalin and gabapentin have been increasingly prescribed in the UK with a tenfold increase in the last decade. Initially licensed for the treatment of neuropathic pain, occasionally anxiety and epilepsy, what we've found is that increased prescriptions have led to a huge increase in the number of deaths mentioning these drugs. A 15-fold increase, in fact, from before 2012. In fact, there were more than 150 deaths last year. And that increase in overdose deaths matches the rise in prescriptions. It's a very familiar story. I think one of the reasons is that increasingly pregabalin and gabapentin have been used off-license. They're rarely the first choice for anything. The first choice treatment for neuropathic pain is not pregabalin, it's tricyclics, low-dose amitriptyline, for example. But patients presenting with other sorts of pain, I think, were perhaps more likely to be given pregabalin than opioids because doctors thought there was a less risk of them developing problems. It didn't take long for patients with opioids to realize actually that pregabalin or gabapentin enhances opioid-related euphoria, and in fact it can also offset withdrawal. And in fact you don't even need opiates on board. If you just take lots of pregab on their own, you'll get a nice buzz. But the real risk, and what we're now seeing, is that in high doses, gabapentinoids enhance respiratory depression. And in fact, opioids were involved in over 90% of gabapentinoid deaths in 2016. Also dangerously, particularly within the prison system where there are a lot of people who want to come off methadone but want to stay on pregabalin, is that in low dose, pregabalin reverses tolerance to heroin. That means people are leaving prison off methadone or buprenorphine and then using heroin and overdosing and dying. So what should the response be? The first thing is that prescribing opioid medications is not like Mastermind. Just because someone started a prescription, it doesn't mean you have to continue it. Patients and their conditions are continually changing, and doctors need to reassess the appropriateness of any prescription medication. And I know doctors don't like stopping medication that someone else has started, but it just might be the right thing to do, if only as an experiment. And the fact is that if doctors prescribe less drugs, there will be reduced access to currently the biggest source of supply. I do understand that's likely to change as the darknet grows, but if doctors prescribed less, there would probably be less harm in the community. As I've said, I think that an awful lot of work can be done in correctional facilities where there is a great opportunity to assess people very carefully and to bring people off drugs like pregabalin or gabapentin very slowly. I do think within the prison system and in the community you need to have a really good reason to have people on both opioid substitution treatment and gabapentinoids. Both methadone and buprenorphine are really good painkillers, and although there will be exceptions, I think you need to have a really defensible reason why you'd be giving someone a big dose of methadone and a big dose of pregabalin as well. But most importantly, I don't want to be leaving people in genuine need of help in pain. But I'd also kind of remind you that there are a whole range of other effective treatments out there that don't get you high or kill you. Now, some of those are medications, but the truth is there's a whole world of treatment for pain that's actually really important. And we just don't pay enough attention to them. So you can think about things like acupuncture, TENS machines, physiotherapy, osteopathy, exercise, weight loss, yoga, CBT, mindfulness. And the truth is that people with chronic pain very often extinguish all hope in their doctors, and doctors don't feel they know what the best option is. But alternative practitioners very often can spend the time and give them the attention to understand their needs in a much more holistic fashion. So do please think outside the box. Finally, I just remind you that one of the basic principles of good medical practice is informed patient consent. Give them a treatment plan, outline provisional doses and duration, highlight the red flag behaviours that you're going to be concerned about, highlight interactions with other medications, particularly alcohol, make sure they store their medications out of reach of kids in locked cabinets, and remind them of the implications of selling on medications that can kill people. And you need to do all of that without stigmatising their treatment. And I also think it's maybe worth just having a standard letter which you can send out to patients who you start on prescription opioids. I'm not expecting you to read this, and I'll send a copy out to you. But it basically says, look, I'm giving you this medication because I'm assuming what you've done is told me the truth, and I'm trying to give you medication that's going to work. There are going to be things I'm going to do as a doctor to make sure that you stay safe, and that I'm going to ask you to do to make sure that you keep your medications safe, store them safely, don't sell them, don't give them away, and just be aware of the fact that I'm going to monitor you. That sort of communication is really, really important. My final message is that good clinical decision making and transparent communication with your patients are some of the most important things you can do as doctors and healthcare workers working in this field. And I guess my 3 take-home points that I said right at the beginning is that we've got a huge responsibility to make sure that we use these medications appropriately. We have a responsibility to inform patients about their responsibility, and that there isn't going to be a pharmacological solution to what is a deep social problem. But there are a whole bunch of other ways that we can help patients with chronic pain outside prescribing medications that in overdose end up killing them. I hope that's been really useful, and if you've got any questions, please email me, and I hope the rest of the day is really interesting. Take care.